Yeah, I think what we have news pretty much every meeting. So
Mm-hmm.
during my presentation, I tried to focus on diffuse large B-cell lymphoma or large B-cell lymphoma, the aggressive subtype, and follicular lymphoma as the indolent subtype. Of course, there's some results in other types of lymphomas, including mantle cell lymphoma, but it's difficult to cover everything. And I would say that regarding B-cell lymphoma, we have now in Europe and US two products approved, glofitamab, which is administered IV for a limited duration, 12 months, 12 cycles, it's about a bit longer than 8 months, and epcoritamab, which is administered subcutaneously until progression. And both trials and the trials that led to approval are phase 2 trials, non-comparative, and they included a similar number of patients, and at this time they have a quite similar follow-up between 18 and 20 months at the last presentations at Lugano meeting last year and ASH meeting. So what we see is that we have a overall response rate that is 50 to 60%. And we have a complete response, which is about 40% for both agents. And both translate in very durable responses if they are complete responses. Meaning, if you look at glofitamab results, about two-thirds of the patients that are in complete response maintain this complete response at 18 months follow-up. If you look at epcoritamab with 20 months median follow-up, you have a 21 months duration of complete response median. And these trials are still ongoing, so we'll probably see more developments. And we are also already seeing a lot of developments in terms of combinations of these monoclonals with chemotherapy, with other immunotherapies, with antibody drug conjugates. But these results are still a bit preliminary and a bit exploratory. But for the time being, this got us the approval of these two antibodies for the aggressive subtypes.
Yeah.
And we got mosunetuzumab approved for the follicular lymphoma. Mosunetuzumab is less effective in the aggressive subtypes, but it achieves a very good response rate and complete response, also around 60% complete responses in follicular lymphoma. And this is quite durable. And we have to take into account that follicular lymphoma is very heterogeneous, and we have many options besides chemotherapy. But after a while, when you are at third line or after second line, you really are in trouble because you don't have a standardized choice. And many patients get resistant to chemotherapy, and they need an alternative mechanism of action. So bispecifics come here as an attractive option. We are not sure, neither in diffuse large B-cell, neither in follicular lymphoma, we are not sure they will be curative. We have not seen yet a plateau, but we believe that with further follow-up, we might still understand better the curative potential of these drugs. Also, they have some advantages because we tend to compare the results with the results of CAR T cells. The mechanism of action is not that different. The complexity of the treatment with bispecifics is much lower because we have it as an off-the-shelf medication. We don't need to do lymphodepletion. We don't need to wait for manufacturing. So we can, for some patients that cannot really wait this time, this might be a more attractive option. Maybe in the future, when we learn more about treatment with CAR Ts after bispecifics, they might even be used in the future as a bridge, but the truth is we are not sure this will be possible. For the time being, we prefer to do the opposite, to use first CAR Ts in the patients who are candidates and have access, because it's not uniform in everywhere, the access to CAR Ts. But if we can, if the patient is a candidate, if we don't anticipate too much toxicity, we prefer to use the CAR Ts first and then to salvage the patient if it doesn't work with bispecifics. We already have also interesting trials using bispecifics as maintenance after CAR Ts, which is also interesting in aggressive
Yeah.
lymphomas.